Hello and good afternoon, everyone. Welcome. Thank you for taking the time to participate in today's live webinar with OARC. Our session today is about supporting residents living with cognitive changes during the COVID-19 pandemic. Before we get started, you'll notice that all phone and audio lines have been muted in an effort to eliminate background noises and distractions for our presenter. We have protected time for a question and answer period at the end of today's webinar, at which time we'll invite you to type your questions into the chat box or unmute yourself to ask your question out loud. Our session today is being recorded for education purposes and will be archived on the OARC website. The webinar slide deck is available for you now under the Materials section of the training toolbar. We will also share the slides along with the recording of today's session with all participants via email early next week. At this time, I'd like to invite OARC's Director of Education and Community Engagement, Josie Lee Gibson, to formally begin our session today and introduce our special guest.
Thanks, Melissa. It's my pleasure today to introduce our guest speaker, Dr. Alan Power. Dr. Power is an internist, geriatrician, and Schlegel Chair in Aging and Dementia Innovation at the Schlegel University of Waterloo Research Institute for Aging here in Ontario. He is also a clinical associate professor of medicine at the University of Rochester, New York, and an international educator on transformational models of care for older adults, particularly those living with changing cognitive abilities. Dr. Power has a 20-year history of working in culture change in aged care. I welcome you, Dr. Power, and I will now turn it over to you.
Thanks so much, Josie Lee and Jennifer, and welcome everybody to the webinar. If there's any problem hearing me, just break in and let me know, but right now I think we're doing okay. This is a great topic, I think, and a timely one. I'm not going to spend our whole time talking for a couple of reasons. Number one, I think sometimes the discussion can be very helpful as much as any slides I prepared, but also because I know that there are both people living in a retirement or possibly long-term care on the call, and there are also some people who work in these areas. And we're already 3 or 4 months into this, and I know there's been a lot of creativity out there. And so I would also, in addition to taking questions, love to engage people who would like to share some of the successes they've had, some of the things they've thought of to help people to cope during these unusual times. So I've just got about a dozen or so slides, and I'd just like to run through them with some general principles, and then we'll break for a good discussion. Let me get on here. There we go. So regardless of where you live or how your community is designed or how new or how old it is, I don't think I've ever heard of a community that was actually built with a pandemic in mind. So one of the biggest challenges that we all face, no matter where you may live or work, is adapting environments that were never specifically designed for pandemics. But that's more than just infection control, because we need to balance infection control with other considerations, quality of life, and things like choice, autonomy, connectedness, maintaining relationships, feeling safe, all those various things. And that's not easy. There's no right way to do that because you are balancing two often conflicting ideals. When Josie Lee mentioned the culture change movement, that is something that has been an effort to try to change the places where older people live. It started mainly with long-term care, trying to change them from institutional hierarchical type places to live and work more like hospitals, and to change them more reflecting the values of a home, not only physically, but looking at the operations, looking at how we relate to each other, and saying, is this really something that focuses on the needs and preferences and the uniqueness of the people who live there or not? And that's where terms like person-centered care or person-directed care have come from. So that's an important message. And just because we've had this pandemic, in spite of the difficulties we've had and the deaths and the illness, it doesn't mean that we should change everything into a lockdown for all time, because we need to have a life worth living too. So beyond that tricky balance between quality of life and safety is also helping people who may not be able to remember or to maintain precautions for various reasons. And of course, that includes people with cognitive challenges, such as a diagnosis of dementia. I do a lot of talking about people living with dementia, and I think this has been on most people's minds since the pandemic started. I've certainly had a lot of discussions around this topic. So I'll give you what I've learned, and we can go from there. So there are a few things that should already be done wherever you may happen to be. Plans to cohort any affected people as far as possible. And that involves not just moving people necessarily to one area, but looking at things like floor plans, looking at the ventilation, looking at how staff move throughout those spaces, not having people casually entering spaces that are not working there, how food is delivered, all those kinds of things too. Consistent staff assignments as much as possible. This is something that I and others have been advocating for a couple of decades. And I think that this really shows the importance of having the same people supporting the same people and not a lot of different people coming and going and providing personal care, because that just increases the risk of infection for everybody. There's been restricted visitation, of course. There's been protective equipments, sanitizers, special disposal processes, special cleaning processes. So that's already done. There's active surveillance going on now in, I think, pretty much everywhere of residents and staff to make sure people don't have symptoms, checking temperatures periodically, et cetera. And working maybe perhaps with your team to help brainstorm any challenges they have with transportation, childcare. When now the school is out, childcare is closed. Are people able to get to work? Are there things you can do to help people to fill shifts? And of course, working with our activities professionals to share ideas for meaningful engagement with all the restrictions we have in place. So how can we help those who cannot remember these precautions? And there's several things that I'd like everybody to think about. First of all, a bad news, good news scenario. When we use terms like person-centered care or individualized care, I think it's really important to understand that even though we talk about these, we throw these terms around a lot, and sometimes the institution or other priorities get in the way. And I think that when you're talking about people living with dementia who are having trouble maintaining precautions, our need to understand what this individualized support really means is going to be challenged, has been challenged more than ever before. The good side is that what we learn during this time will greatly advance our ability to understand and support and engage people after the crisis has passed. So this really is a tremendous growth and learning opportunity. And I hope that people will not only react to the challenges, but see and pay attention to the things we're learning. I had a conference call with a group of leaders at Schlegel Villages, where I work part-time, and they had noticed a lot of ways in which people living with dementia were calmer and happier since the pandemic. And so we were able to peel that apart and find 6 or 8 different things that had changed that actually created a calmer environment for people. And it may not be that way forever, but how can we take those things like consistent staff, like fewer interruptions, like fewer people walking through and creating noise and commotion? How can we take those things and then extend them to life after the restrictions are lifted? First thing I want to talk about, though, is terminology. And I think this is really important because people say when you can't maintain precautions, people are wandering, they're leaving the room. So let me just suggest a couple of language changes here. I want to remind everybody that for those of us who are able to walk, walking is a normal daily human activity. Wandering and elopement behavior are labels that judge and actually pathologize the person's intent. If we walk and nobody asks a question about it, we leave the building, we come and go, we exercise, we stretch our legs, we get our Fitbits and do our steps. And sometimes we just wander aimlessly and nobody questions that. But I think we often hold people living with dementia to a higher standard than we do ourselves, because once they try to do what we do, we label it, we pathologize it, and we often do things to try to stop people. So just remember that walking is normal. What's not normal is putting people in a place where they cannot walk freely. And so we have to deal with that bit of a challenge when we get into situations like this. So why might people try to exit their room even though they may test positive or may be at risk of being exposed to others? Well, I think there are 3 main reasons. One of them is the one we never forget, and that is that people are simply curious, exploring, or following their normal impulse to walk every day. But people also try to leave a room or living area because they are distressed or not comfortable. And to look at the two reasons why that might occur, I look at it very simplistically. For starters, people are often trying to find something that's not there, or they're trying to get away from something that is there. And these somethings are usually not a tangible object or even a person. It could be looking for a place where they feel safe. It could be looking for meaningful relationships. It could be looking for meaningful engagement, something that speaks to their values or what they want to do at that point in time. It could be looking for a sense of choice or control over a situation. So once again, there are a lot of reasons, and we have to look at it through a non-pathological lens and say, okay, what is the person communicating if they want to leave? What are the many needs or preferences or choices that the person may be expressing if they cannot necessarily tell us that in so many words? And how do we not just say no, but how do we help honor these choices in the safest way possible? Two big cautions for everyone here. For affected residents who cannot remember, first of all, physical restraints are dangerous and they will increase people's distress and the risk of injury and death. This was proven decades ago. Restraints should be gone and they should not be any kind of a consideration. Now, there are two things that may not seem like restraints, like seatbelts or restraint vests or those types of things, but also things to consider. And that is, people have talked about the idea of locking people in their rooms. That's pretty much a distressing restraint too. Imagine being worried about fire or just feeling claustrophobic and then having a locked door and not being able to get away. That would, to me, would be incredibly frightening for people. And as a matter of fact, one of the things that some people living with dementia have is a change in their sense of smell. My friend Agnes Houston, who lives with Alzheimer's in Scotland, will occasionally get a funny odor that's caused by the Alzheimer's in her brain that smells like smoke, like something burning. So imagine being locked in a room or locked in a living area and having this odor that people don't recognize that you smell and panicking because you think there might be a fire and you can't move or get out. The other restraint that we don't think about often is that many living areas are secured with a locked and keypadded door. Once again, we don't think much about that, but for a person who needs to move, we have to think about how does it feel to be confined within a space, particularly more active people who may have walked all the time when they were younger or in their career and still have that daily need to do so. For any of us, I think for anyone on this call, no matter what your age is or whether you have any medical diagnosis or not, I think if any one of us was put in a small room and told we had to stay there for 14 days, I'm not sure how many of us would make it. I know that I would not. And this is the other caution. Sedating drugs are potentially dangerous to use. And we're talking about antipsychotic drugs or other drugs that primarily sedate people. Remember that even though people have advocated for using these when people walk where they shouldn't or do things they shouldn't, there is no drug and there never will be a drug invented that reminds people where to walk and where not to walk. There's no drug that tells people to stay 2 meters away from other people. There's no drug that reminds people when and how to wash their hands. So when we use these drugs, we have to recognize that the reason we're using these is to sedate people. And sedation for people who walk is always dangerous, increase the risk of falls, but also not only the other side effects to those drugs, but when you have people who may already be infected, seriously infected, who may have decreased oral intake, who may be more unsteady on their feet, who may be febrile, the risks that these drugs cause of further dehydration, injury, death, dangerously high fevers, which can be a side effect of these drugs, there really is not a reason to use them for this reason. And I hope people that are avoiding them because I do believe that this is not defensible in any kind of a medical way. So what are some possible steps? Well, the first thing is let's make the room as desirable as possible for a person. So maximize the degree to which that affected person's room can become a space where they can experience comfort, belonging, a sense of identity, feelings of security, and where they can find meaning in daily activities. And that's more than just decorating the room or putting in some reminder objects that can help, but what are the things that the person engages with in the room? What's important to them? How can they spend their time in ways that interest them? And are the things that used to interest them in groups outside the room where they can be engaged within the room? Reframing behaviors, as we often use the label, as legitimate responses to a very trying situation. Remember, dementia did not cause the situation, but it can affect our ability to cope with the stress of the situation, to communicate our needs, to remember what we need to remember. So to say that these are symptoms of dementia, I believe is incorrect. These are symptoms of what all of us are feeling in a very challenging pandemic, but dementia does enable distress or modulate how we respond to the stress by making us less able to solve problems on our own or to remember what we need to know. So look at attempts for people to leave as attempts to find what is missing in their life at that moment and or to follow their natural instinct to move around. I think at this point that it may be unreasonable for someone who is constantly trying to move to say you can't move. Number one, it's going to be impossible pretty much. It will increase people's distress, but even more so, it also not doing things is dangerous too. And that's why I talk about these tricky balances. So it may be risky for a person to walk around if they're positive or other people are positive for COVID, but it's also risky to sit all day, especially for older people who may quickly become deconditioned, lose their muscle strength, lose the strength of their lungs. And we know how important diaphragm strength and being able to cough and breathe deeply is if you get infected with COVID, and how it can be life altering. So sitting still can be dangerous too. There is no risk-free environment. My friend and colleague, Dr. Bill Thomas, once said the only risk-free human environment is a casket. So how can we find ways when a person is constantly trying to walk to help that person to walk? Well, one is to help the person, to follow the person, to accompany the person, and facilitate cues to help the person remember those things that she may not remember. So remembering not to get too close to people, remembering about how to touch things, or not to touch things, remembering when to use hand sanitizer or to wash hands. But we can make activities out of hand washing. We can share it, do it together. Even make some sort of a game out of it. And remember that part of the reason when people walk, they have trouble is that they don't really know where they are, because so many of our senior living environments are created in ways that the aging brain and the aging eyes and ears can't make sense out of. And having just designed an environmental audit with a student of mine and testing that in long-term care and also assisted living, you can see how the design of places really does not accommodate the changing perceptions and the changing needs of people living with dementia or other types of cognitive change. So make sure the signage is right. Make sure reminders are where they need to be. You may have to put up signs saying, I'm sorry, some people actually hold up signs when they come in the room with a mask on. Hold up a sign that says, my name is so-and-so, I'm here to help. And, I'm in a series of signs. I'm sorry, I have to wear a mask. There's an infection and we want to protect you. Things saying, let's wash our hands, or things like that to maybe help the person so they can read. Because if they can't read your lips through a mask, that can be a problem too. Other people will walk around with pictures of themselves, maybe safety pinned to their blouse or their shirt. Or maybe some people use a plexiglass face shield or a mask with a clear center in it that can be specially made so that people can see your lips moving. So there are different ways to try to recreate that sense of familiarity, because for many people that have trouble with facial recognition due to dementia, even if you regularly support somebody, walking in the room with a mask on can be disorienting and maybe a bit frightening to some people. So think about the environment, walk around the environment, looking through the eyes of a person with older eyes, older ears, older depth perception, or older ability to discriminate different shades of color so that contrast and borders are hard to find, so that dark spots in the floor may look like holes or steps to a person with dementia, and understand how that may or may not increase a person's level of distress, and really work on that. And also for other people who are not affected, who are concerned about people coming in their rooms, they can also self-isolate when they want to be in their rooms by closing their doors. Some people use the Dutch style doors with a half door that opens. Some people have reported that many people who will tend to walk into other people's rooms will often stop when they see a half closed door, and they may look in, but they don't try to get in. So that for those who have those kinds of fixtures, that can be helpful as well. And also remember our nonverbal communication. We're talking about trying to minimize the stress and improve calm in a group of people. And we are stressed. Let's face it, this pandemic is stressing all of us out. And those of us who have to work in long-term care or retirement have those risks, have all those needs to constantly protect ourselves, to think about our own personal protection. We may have sick family members at home. We may have concerns about kids left at home with school being closed. All of that can affect our nonverbal communication, our body language. And remember that people that sometimes can't see our lips moving or have trouble understanding our words, have trouble remembering things, really are very attentive to body language. So if our body language looks distressed, defensive, unhappy, a person living with dementia may pick up on that, and that may be the way that they react to the way they see you. So the more we can do to be self-aware, to try to find a bit of presence and mindfulness before we ever approach a person living with dementia, the better we can do. And anything that you know about the best ways to communicate with people living with dementia, to do all those things, to introduce yourself, to sit down, to connect with the person before trying to start a task, to understand how they communicate, to help facilitate their ability to be understood. All those little tricks of the trade become so important during a time like this. So that requires a certain amount of one-on-one. I understand that, and I know that sometimes staffing levels can be difficult, but that's another thing for you to do as an organization, is if there is an individual who needs to walk several times a day, how can you accommodate that? How can you work together? How can you free up one person, maybe share each other's non-personal tasks so that at given time a person can break away and spend some time walking with somebody? Or, you know, as we say in basketball, if you're a Raptors fan, there's one-on-one defense and there's zone defense. So if there are a couple people that want to walk, is there a way that a team member could engage a couple people and sort of follow them around or float between them, and once again use the cues and reminders? I understand these are not perfectly hygienically sterile situations, but once again, we're balancing the reality of what it's like to have several people in a living area who might need to move, compared to the dangers of forcing people to stay in the rooms, giving them dangerous medications, et cetera, et cetera. Remember, and I know I'm down here in Rochester, New York, and I'm sure you're all watching the crazy stuff going on in our country, and you may have a little bit up there, although it's probably not quite as crazy as here. But when you think about, for example, back at the beginning, all the young college-age students who went on spring break to Florida and went to the beaches and would not follow any recommendations about masks or social distancing. Or if you look at the big rallies, you know, in the Trump rallies in Oklahoma and Arizona this past week, and see the people gathering closely without masks. This is obviously not smart. People are going to get sick. It's not good public health measures. So we know that it's not good. And yet I've never heard anyone suggest, well, let's lock these people up or let's give them antipsychotics. So once again, we can't hold people to dementia to a different standard. We know that there's risk with what we do. And we know that we're all human and we have to balance risk with reality as well. A few approaches to engagement. I'm hoping we're going to hear a lot more during our discussion in a few minutes. For one-to-one engagement, just talking to a person, it does not have to be an activity. I guess that's really my important message. We always think, well, let's play a game, let's watch a movie. Well, sometimes people can't attend to those things or don't want to. Maybe what people are really reaching out for is just connectedness. So sitting and talking to somebody, looking out the window together and commenting on the world going by, listening to music maybe, and of course we know about personalized music, things like the iPod project, music and memory, and those can be very useful. But once again, sometimes people can engage by themselves, but sometimes they may want to talk about what they're listening to. So if you have somebody from activities or really any team member, because once again, one of the things you have to do to think outside the box is not really lean on our rec team members to provide all activities. It may mean a PSW is providing an activity at one point. It may mean the social worker is providing activity. In my case, as a doctor, sometimes I've engaged people when it was needed and everybody else was busy and I had some time. So think about the fact that you are a team. And if Mary Jones needs some help, how can the team help Mary Jones 24/7? Not it's up to this shift or this job description or that job description. We really have to be creative here and we have to really work with a collaborative approach. So it's really more about being than doing for a lot of people. And remember that for many older people, epidemics and quarantines are not new. You can talk to people about this. You can talk to people living with dementia about what it was like in their life living with quarantines. I experienced a quarantine in my own life. I'm not as old as most people in retirement or long-term care, but back in Rochester and back around 59, 60, there was a blizzard and an ice storm and a power outage, and my sister got the measles, and we were basically quarantined. The doctor would come out to the house and check on her, and we were all living up in the living room around the fireplace because we didn't have any power to the stove. And so even, at my age, I can talk about my experiences. And sometimes that can be calming to just talk about and remind people, oh yeah, this happened to me when I was a kid. I guess it's happening again. Here's a picture of some people using social distancing for meals. So some people have found the solution of having people eat in their rooms, and that may work, but it doesn't have to be that way. If you can find a way to keep people 6 feet apart, if you can find a way to keep people during activities more than 6 feet apart. I know in the local greenhouse homes that I helped to open here in Rochester, New York, there's small households with only 10 people living there, and they're used to eating at just a family table with all 10 residents and a few team members sitting there assisting and eating with them, maybe a family member visiting, sitting at the table, and that was normal. So now they have this, but they don't want to have 10 people in their rooms because it's such a family atmosphere. So they have a couple people, maybe 3 or 4 people spread out at the big dining table. They may have a couple more with TV trays in the adjacent living room. It's all an open floor plan. They may have someone sitting at the counter. There's a wheelchair height counter outside alongside the kitchen, so the people in wheelchairs who want to help prepare food can cut things or sort things there at that counter. So maybe 1 or 2 more sit there, and then maybe the team members float between people and assist them as needed. So there are ways that we can work around this. Remember, we just have to be creative. We know the guidelines. The guidelines are 6 feet without a mask, masked for less than 6 feet. So how can we work around these guidelines? And of course, for people who can use technology or can be helped to use technology, virtual engagement through various approaches. And we know that there's video email. We know that things like Zoom or WhatsApp, or like we're using now, go to training. But also many people have opened their websites. So a big orchestra may have online concerts. Museums have tours. You can go to the Louvre, or you can go to the Metropolitan Museum of Art, probably one in Toronto too. And you can log on their websites and they can give you virtual tours of their artwork, of their museum artifacts. Of course, there's TV shows, games, photo galleries, all kinds of things. There are several websites that have lots of virtual engagement resources, particularly that might be useful for people who are feeling the stress of isolation, particularly maybe people living with dementia. The Pioneer Network, which is pioneernetwork.net. You can Google that. Dementia Action Alliance has a great list. Time Slips is a wonderful engagement suite that has been designed by Ann Basting. And she at timeslips.org, I think it's .org, you can find all kinds of amazing engagement for people. And my friend Karen Stobie, whose group is called In the Moment. And this one, there's an In the Moment that's not her. So I think it's like in-themoment.com or something like that. So you can find, and I can get these exact websites if you need them. And Ann Basting gave a wonderful webinar a couple months ago on engaging people during the pandemic. And she reminded us, because Ann was a theater major before she started working with people with dementia, that the rule of improv comedy is always to say yes and. So if somebody starts a skit and it gives you a premise, no matter how ridiculous it is, if you say, no, that won't work, or I don't want to do that, well, then the skit stops dead and you've just killed it. So the way to make improv work is to always take what the person says and then add whatever you want. And once you do that, take it in any direction you want, but don't destroy the premise that came before. So Ann's reminder was that maybe what we should be doing when we get all these restrictions and these regulations coming down the pike from the ministry is, as workers and as people living in senior living, we should say yes and. Yes, we have to stay 6 feet apart, and here's how we can do this activity. Yes, we have to wear a mask, and here's how we can help people go outside, or how we can help people with meals. And so once again, this idea of creativity that comes with this mindset can really be a boon during trying times like this. And once again, I think there'll be people on this call who have got some great ideas. Every time I'm on a webinar on this subject, the people that work in either retirement or long-term care come out with all kinds of wonderful ideas. So I'd like to stop at this point. We got plenty of time in the hour, and I'd like to hear from people any of these things. What are you doing where you live or work? What have you learned, good or bad? What is your advice for other people who are challenged? And what questions do you have for me or anybody else on the call? What challenges are you facing that maybe we haven't addressed in this quick talk that we could talk about? So I'm going to leave that there, turn it back over to Josie Lee. And if you'd like to just go through the chats and post some questions or comments, I'll be happy to weigh in as best I can.
Thank you, Dr. Power. Just while we wait on some questions and comments and sharing to come through on the chat box, perhaps I'll just jump in to get us started. Sure. One of the challenges that we've heard from many residents is around the lack of communication that they've been receiving from their homes, the feeling that they've kind of been left in the dark and that they're really fearful of what they don't know. And I'm just wondering if you could weigh in and maybe give some guidance for how homes can communicate the why certain things are happening. So why they're having to stay in their rooms, why they can't see their loved ones, to all residents, including those with cognitive changing abilities.
Yeah, that's a great question. And you know, as you mentioned early on, I've been working in this culture change movement for now going on 23 years. And forget about pandemics. Whenever we get into organizations and talk about organizational changes and what the struggles are, and you ask team members, not to mention residents, but also team members, what the biggest challenges are, one of the biggest ones that always comes up on the list is communication. You know, if we were playing Family Feud, that would be one of the top two choices every time for staff members and for residents. So I think it's a good time for any organization, any home or community to look at how you communicate information and look at all the people who are stakeholders in your community and how do they access information. So who reads emails, who looks at bulletins on the bulletin board, who needs to have something told to them in person. You know, who do you have at the home I worked at last, there was a dedicated TV channel, and they would show religious services over the TV, but they would also sometimes have educational series or announcements too. So a different way of doing it. So I think without giving one answer, I think each home has to look at what their processes are, who is missing out on the message, and who may need a bit more explanation, because your question makes it sound like not only am I not being told what the restrictions are, but maybe people don't completely understand why I have to stay 6 feet away, or why do I have to wear this mask if I'm not sick? And you know, let's face it, we've all been struggling here. We've all been rotating 180 degrees on what we think is going on. And just me as a doctor trying to follow the science of this, I've changed my mind a few times. The researchers I read have changed their mind. At the beginning, I didn't think masks were a big deal because I thought it was all droplets, and just like the common cold, you want to be careful what you touch. But now, you know, I've been convinced that masks are a big part of this, particularly if you are infected. Wearing a mask for the sake of others is a huge thing. So now I wear one everywhere I go, you know. But so I think we all learn, and because it's a moving target, a changing thing, and because the slow opening up is going to change, I think the regular bulletins are really important. One thing they've been doing at Schlegel Village is they've had a daily briefing. This is for team members now. I'm not sure if it gets to the residents or not, but you may need to adapt this to people who live there. But basically, they give a summary. You know, what villages or what areas have been affected by infected people living or working there. You know, what are they doing? What are the new regulations? What are the new steps they're taking? And why? The why, as you say, is really important because not all these things are intuitive. And so just say we now have to do this may not be enough for a lot of people. So yeah, I'm just going to turn it around and say your question is a really important one, and it means that for each unique organization, you need to be asking yourselves these questions, asking your residents these questions. What are you missing? What don't you understand? How can we communicate better? Because sometimes we just assume that the message goes out and we don't think about this until someone raises it. So great point.
Thank you. We have another question in the chat box here asking for you to weigh in on a certain approach. And the approach is if a team member enters a room and lifts his or her mask so that a resident can see the full face, smiles and introduces him or herself, and then says, "There's an infection and I want you to be safe. I'm sorry that I have to wear this mask and want to keep you safe." What would be your opinion on this approach? Is it appropriate?
I think
Is
it's
it
a wonderful
alternative?
approach. The only caveat is do that from 6 feet away. Don't walk right up in the person's face and then pull the mask off. They may have trouble seeing. You might have to get closer than standing in the doorway. But what I always recommend whenever we enter a person's room, particularly a person with dementia, even when there's no pandemic, is to always start by knocking on the door of the room or the apartment, identify ourselves, ask permission to come in, and then wait for that permission and then come in. And then when you get within eyesight, by all means, take off your mask, say it's just me, explain what's going on. The other thing I also recommend, that of course increases people's feeling of security, having people always ask permission before they enter their space, but also a sense of control over the space too. The other thing that I always recommend people do, particularly if you have people that might be resistive to your attempts to help them, is to start by just saying, "Can I come in and visit for a moment?" Don't start with whatever task you have to perform, because no matter how nice we are, we have to think about this through the eyes of a person living in a home. And that is, no matter how nice we are, no matter how much we try to help, if every person who comes to the door says, "Hi, it's Josie Lee, I'm here with your medication," or it's Jamie, it's time for breakfast, or it's Jennifer, we have a wonderful movie going on in the lounge, or it's time for a bath or whatever, we are announcing what's about to happen. So no matter how nice we are, the message we're really giving people is you have no control over what's happening here. We're coming here and telling you what you're gonna do next. And for a lot of people, that can be just enough to really get people feeling resistive because they just don't have any say. And so when people really clamp down around having a bath or something, it's often because that's the one place where they can actually exert control. They can't control you coming in and saying what you're going to do, but maybe when it comes to actually getting in the shower, I'm gonna be resistive because that's the one time I can exhibit a little bit of authority over my life. So sometimes people become much less resistive if we make sure they have control over every situation. So don't start by saying, "We're going to do this." Start by just saying, "Can I come in?" Getting permission to connect and talking to the person for a second, and then saying, "Hey, I've got some morning medication. Are you ready to take some pills?" Or, "Oh, we got a great breakfast cooking. Would you like to come out and join us?" Something like that, a little invitation. So these tiny things, they may seem small, but sometimes they set the stage for a good interaction or a bad one. And I've found that just using these kinds of tips right from the moment you get to the room can be really helpful.
That's great. We've had somebody online that's sharing a few of the things that have been happening in their home.
Good.
They had a campfire today for residents, and they've
Nice.
also had a loved one playing guitar virtually over the TV screen while they sang along.
Oh, that's great. That's great. And once again, being as creative as possible. And you not only have the music, which connects people, but when you have the familiar face, familiar voice singing the music, that can be really reassuring for people. We saw a picture on my slideshow of people visiting outside the window. My mother's in a retirement independent living home now, and she's on the ground floor, fortunately. So we're not supposed to go in and see her. I occasionally will bring groceries to her, but what we do for the most part, like when my family is up visiting with me, is we go outside and knock on the window and turn on the phone and talk to her on the phone through the window. There have been these drive-up, plexiglass booths. People have done that. There's lots of different approaches to connecting people. And once again, I'm going to be a little bit controversial here, and maybe the ministry would say no, but I think once again, I said this is a place where we have to really individualize. If there is somebody who is clearly suffering, who's clearly declining, because they are not connecting with an important person, a spouse or partner, or an important son or daughter, why can't that one person observe precautions and come up with a care plan where at certain times they come in with gown, with gloves, with masks, spend time with their loved one using the precautions. And once again, that means we have to be willing to say, not everybody, you don't need it, but your neighbor does. And this is part of that person's unique care plan. there's a lot of potential there for a conflict and saying, that won't work, or what about me? But if we're really going to individualize, I think there's some people where the risk of having a family member there is less than the risk of keeping them away. And same with volunteers. A volunteer can be trained to follow the same precautions that the staff member can. So I think now that we've seen the effects of the isolation, we got to start once again saying we're balancing two things here. There's no perfect world. We are not eliminating risk. You can't do that. We're negotiating risk. We're negotiating the good with the bad and trying to find the best balance for each individual. So once again, if you have moved down the place where your thinking has gone beyond pure institutional, broad brush, everybody has to do the same thing. This is the next level of engagement, I guess, is how do we even individualize further some of these restrictions and get around some of these when people truly need them.
Thank you. Our next question comes from Park Lane Terrace, and it's a bit of a loaded question.
Okay.
But it says, you mentioned using a multidisciplinary approach for programming. How do you make that happen? The healthcare industry is still very task focused. How do you get everybody on board? Rec staff are always the most limited, although rec is called to take on those extra roles. Skyping, FaceTime, outdoor, window visiting. So how do we get that full team approach?
It's not easy, and a lot of it depends on sort of the climate of your organization when you start. So some organizations, have a ways to go as far as teamwork, and they still have place where people come in and they're very defensive or very pessimistic, and they're saying, that's your job, this is mine, or I'm watching out for myself. And if you have a lot of people in that mindset, this can be a tough sell because that's not the culture of where you are. So this is the culture change path. It takes a lot of what Eden calls soil warming, before you can get new ideas to grow. So you have to cultivate that spirit of teamwork, that spirit of positiveness and collaboration. And so the best way to do it, I think, is to engage everybody. Don't impose this on everybody and say, okay, you PSWs have got to start doing this 3 times a day or something like that, where people have no choice, because people who work in senior living want to have control just as much as people who live there. So really, we have to sit down, and once again, we have to come with that spirit of teamwork. We have to sit down as a team and say, listen, we have these things that need to be done. We have these people that need these kinds of activities. How can we work together to make that happen every day, not just when activities professionals are here? And if people say, well, I'm too busy, I have too much to do, then we say, okay, then how can we help you do some of your tasks that pull you away from this so that you can do that? And that means stepping outside our job descriptions. It means, I might be assigned certain residents, but if you're going to go spend time with somebody and that's important for the care plan, then I might bring some water to a few residents that you normally would bring them to. Or, if I remember when I worked at St. John's in Rochester, there was a unit secretary in the long-term care home. And the activities professional got married and went on his honeymoon, and he used to sit and read the newspaper every day to the residents so that they could hear what was in the local news. And without anybody telling her, she just took it upon herself, and she got someone to cover the phones for 15 minutes every morning while he was gone. And she went out with a newspaper and gathered people together and read to them. When you have a few people like that that can lead the way and can lead by example, it's so much easier to show than to tell. And then you invite people, you encourage people to join in that same spirit. But it's really about teamwork, and it's really about not me or you or this shift or that shift or your cohort of residents or my cohort. It's about, this is all hands on deck. How do we get through this together?
Thank you. The next question is around virtual visiting, and we've heard that this can be extremely distressing for people living with dementia, as they don't identify with the technology and they don't seem to quite grasp why their loved one is on the screen. So the question is, how can we make these virtual visits adapted to be meaningful for those living with dementia?
Yeah, that's a good question. And once again, there's no rule. It's knowing the person, and it's trial and error. So there's some people, if you can get a family conference on WhatsApp, that'll be great, and they'll be able to talk to them, and it's wonderful. There are other people that won't understand what that means, just like We used to, in the old days, before we had all this technology, we used to have the family members record a reassuring message on the cassette player, and play it for people at night when they're distressed. But even then, that disembodied voice didn't make sense to everybody. It didn't always work. For those people, once again, if the stress is really high, then there's nothing like seeing the person in person. So whether that be, an outside visit, bring the person outside so they can drive up in the car, having the person walk up to a window, visit through a screen, something like that. Or once again, those maybe some really exceptional circumstances where somebody is cleared and taught how to visit safely for particular people where the distress is so severe that it's just disrupting the entire ability for anyone else to work or live there peacefully and causing distress for that person. That's a case where I say bring a family member in is a lot safer than keeping them out. And once again, this is all what I said about individualized care. This really challenges us to look at each individual, and what works for Mary Jones won't work for Robert Smith, because as they say, if you've seen one person with dementia, you've seen one person with dementia. So this really is about trying to come up with each person's care plan, and knowing that we have another 10 or 20 or 30 people with care plans to follow in that area, trying to find the best balance. This is not perfect, and we are human. And I think we also have to forgive ourselves a little bit, because it's not perfect. This is not a bubble, and it will never be a bubble. And the last thing we need after this is over is for the ministry to come down and turn your community into an intensive care unit. There are some things I would like to see happen. I would like to make sure that everybody gets private rooms. I've been campaigning for that for 20 years, and I'd like to make sure that we get consistent staff assignments for close, personal, intimate care. If those two things can come out of this, then it's a good thing. It's a good side of this. But we're not going to create ICUs, because no one wants to live in an ICU. Most people would tell you, and if you ask the residents, they'd tell you, I would rather take a chance on getting the infection, potentially dying, than to be locked up in a sanitized environment the rest of my life in case it comes back. The other thing I might mention too is really talking to the residents about what they prefer. I know a colleague of mine in Australia heard about a home where they worried about family members not visiting, and they talked to the residents, the resident council, and a bunch of them said, you know what? We've lived through hard times before. We don't want to get sick. No, you can keep my family out, because this is important to me. It's important to them, and we'll talk by phone. So depending on the ability of people to stay connected through different means, you may have different solutions. And by working with your resident council and with individuals who may be stressed with trial and error, hopefully you can find the best solution for each group. But I haven't got any other magical technology. There's lots of platforms out there, from It's Never Too Late type proprietary platforms to the conferencing platforms like we're using. So it's really a matter of figuring out what is most user-friendly and what's recognizable by each person.
One of the things that you've been speaking to, Dr. Power, that's really resonating with me is around the importance of balancing that risk with reality, as you say. And there are many homes, long-term care homes, that have gone to the extreme of prioritizing infection control. And I'm just wondering if there's some messaging, some encouraging messaging to the homes and to the management teams that you can speak to that will help them towards finding more of that balance.
I think first of all, I encourage people to continue to engage those discussions. The fact that people even have those discussions and don't just say, no, 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 we can't do that is positive, because people recognize that there's two sides to every coin. And you probably have noticed this. I've certainly noticed it in the States, and I've been in Canada enough to notice it there too, that whether it be our federal government or your ministry, when you look at regulations, either for retirement or for long-term care, there are two groups of regulations which are fundamentally in conflict that put you in a no-win situation. One of them is the group around resident rights. Residents have certain rights. The other one is the regulations around safety. If you are willing to validate and support all the resident rights that the regs call for, then you're going to have trouble with safety. And if you follow every safety regulation to the letter, then you're going to infringe on resident rights. And so I think, in our attempts to create good regulations, we have put people in a bind. And so to recognize that you are in a no-win situation. And when you can't win either way, then we have to do the right thing. And so there are a couple of ways to do that. First of all, to recognize, as I said, that doing something has risk, but also not doing it has risk. So going outside your room has risk, but being forced to sit all day in a room and not move also has risk. You know, having somebody walk where they want has risk, but giving an antipsychotic has great risk. So there is no perfect solution. And so I think what we need to do is just a couple things from the standpoint of, you know, worries about regulators and liability and all that is we really need to have a conversation with all stakeholders. The resident absolutely should always be included in these discussions. And even if the person's living with dementia, make every effort to include that person. And even if they can't have a full discussion, use their actions as expressions of choice or preference. Understand that that person is actually saying what they want, often by what they do or what they don't do, and use that as their input into the discussion. Bring family members in, not so they can necessarily veto what you and the resident want, but don't set yourself up for conflict by not telling somebody what you've decided and having somebody find out something and then be angry. So include stakeholders. In some cases where there's real concern, you might even give a heads up to the ministry and let them know what you're doing and what your discussion has been. But the most important thing is to talk about the risks and benefits, weigh the risks and benefits, come up with the best possible solution, not perfectly safe, but the possible that enables people as much as possible, and document. And, you know, I know this doesn't always happen in real surveys, but what the regulators always tell me is we don't expect that nothing bad will ever happen. But if it does and we come in to investigate, we'd like to be able to open up the record and see that there was some reasonable discussion about what was going to be done about risks and benefits, not just come in and see no indication that there was any thought process behind this. So, you know, having discussions involving all stakeholders, putting the voice and the needs of the resident as high in the priorities as you possibly can, and documenting your discussions, I think, are the best way to do it.
Hi, Dr. Power. It's Melissa speaking. Earlier you touched on the topic of residence councils, and I was wondering if you had any ideas for how resident councils might be adapted so we can continue to carry them out and really amplify that resident voice at a time where they can't meet in the traditional manner of large group programs. But we still want to make sure that residents have a say and that they're consulted and feeling engaged. Any strategies that you might be able to share with our group?
Yeah, once again, it'll depend on where you live and work and how big it is and how many people are on the resident council, some things like that, because the solutions may vary, but some possibilities, you know, where I used to work at St. John's Home was a huge building of 14 living areas and 3 connected multi-story buildings, actually. So there were over 400 residents there, and resident council was usually, you know, 15 or 20 people coming in. But we had a big auditorium that could easily seat 100 people in chairs. So we could still, with some amplification and maybe someone walking a microphone, we could still have 20, 15 people meet in that room and sit 6 feet apart. And with the help of some sound, you know, enhancement, get people meeting face to face. If people are able, using conferencing software, you know, the Zoom, WhatsApp stuff could work, Zoom in particular, or those other Teams, those other conferencing things where people, you know, ideally where people can see each other. So GoToMeeting where you don't have the faces is probably less desirable than something like Zoom. And once again, some people may have trouble with that. But if you have a few team members that can sort of assist people, or if you're doing Zoom from your rooms, if there are a couple of people who can't do it themselves in their room after setup, and maybe this is the place where, you know, when the care team is really stressed, maybe this is the place where the general manager or assistant general manager or some of the people that work outside of hands-on care could be involved and could help people and spell the care staff for other duties. So different ways. And once again, thinking about your communication processes. So just sending a poll around to people in different ways, either via email or via printed page to get a question answered. Different ways of doing it. But once again, some of the people on the call may know better than I do because you've worked with the councils. And I haven't worked directly with resident councils in several years, so you may have some other solutions as well.
Thank you. Dr. Power, it's Dee Lender, Executive Director with OARC. We just have a few minutes left. Thank you for coming. Welcome to OARC.
Thank you.
I have a question for you. Government has directed that essential visitors are allowed to come into the home. I feel that emotional and psychosocial well-being is absolutely essential for everyone. Would you support the idea that a small group of people be approved to be essential visitors so that much of the connection between families and residents, or developing the visiting schedule between residents and families, be carried out by these essential visitors? Just wondering what your thoughts are on that.
I would say absolutely. I would advocate for that. And, there's a few caveats to that, but I wouldn't. I think the discussion's coming around that a little bit because, what we saw at first is we got to stop the spread of this. And so we really locked things down. And once again, I'm not complaining about the lockdown. I am practicing all the precautions that I can in my daily life. But we are starting to see the other side. Like I said, everything has two sides. So we're starting to see the effects of isolation. We're starting to see the effects of the loneliness and disconnection that all people feel, and particularly people maybe live with dementia who cannot find other ways to connect. It's causing some real problems too. So I'm starting to see more policy discussions talk about middle ground. But I think, so I do think that we can advocate. I think we need to start those discussions with the policymakers, because someone was saying to me once about a month ago that this COVID had come in. It was kind of a perfect storm. And I said, what it really is it's a perfect storm in an imperfect world, because the world is imperfect, and we can't be perfect about it. And so the important things, I guess, if it's going to be successful, is you really have to have a commitment to individualizing, and you have to have, I think you have to set up, and once again, I would talk to residents about this too, and not just have leadership decide, talk to residents, talk to the hands-on staff, and decide what are the criteria going to be? Who are the people? What are the situations where we would do this? Because what's going to happen is your daughter got to come, and I want my daughter to come too. And so you've got to have a strong value system. If you're not going to let everybody in the door and you're going to do this as needed, you have to have a strong value system, and you need to let people know ahead of time what that is and what those criteria are, so that people understand. Once again, like the first question you asked, Josie Lee, way back, what are you doing and why are we doing it? Because that is the potential conflict, is that people see it as being unfair. But we have to remind people that fair is not equal. Fair is doing what's best for each person wherever they are. So, equal would be, having, the cartoon meme is, equal has the knot holes outside the ballpark all at the same height. And if you're a small child, or if you're too tall, then you can't see through the hole and see the game. Whereas fair is having a stool for the short one, or setting it up so that everybody is accommodated so that they can access things equally. And so if you're able to connect with your family, if you're able to distance from your family, or able to live without them for a month or two, that's fair that you do that, while other people who can't do that have visitors. That's my personal feeling. Controversial area, you'll get a lot of different opinions, but you've heard my opinion anyway.
Thank you. So I think that will draw us to a close. We're just approaching 3 p.m. and I know that time is very valuable. I want to thank everybody for joining us today, and a special thanks to Dr. Power for lending your expertise and having this conversation. You mentioned earlier on that this pandemic has created many challenges, and particularly in long-term care, finding that balance and of keeping everybody as safe as possible while supporting residents' rights and quality of life has really proven to be difficult. But you've shared many ideas with us today on how to create that balance, and really how to create opportunity for having a life worth living, as you mentioned at the beginning. So once again, thank you very much for joining us this afternoon.
Thank you so much. It's been a pleasure to work with OARC on this, and I hope to meet with you all again someday. Maybe in person when they let me north of the border, but I'm not expecting that anytime soon.
Thank you. Thank you, everyone, and bye for now.
Thanks, everybody. Thanks for your questions.